we are going to take a simple and practical look at STEMI, ST elevation myocardial infarction, and how to understand it on ECG. This topic is extremely important both for exams and for real clinical practice. However, if your understanding is not accurate, the knowledge tends to fade quickly. Many students try to memorize STEMI patterns using NCLEX, but even when I talk to residents, the memorized knowledge usually doesn't help much in real cases. On the other hand, beautiful anatomical diagrams are accurate, but they are hard to reproduce from memory. That makes them impractical during emergencies. So today, I'll explain STEMI ECG using the simple schematic I normally use when teaching students and residents. My goal is that everything you previously memorized becomes three-dimensional, clinical meaningful knowledge that you can actually apply both in exams and real patient care. We won't go into detailed physiology here. STEMI refers to a condition where the baseline from the S wave to the T wave is elevated. What matters most is that the ECG reads showing ST elevation depends on the location of the infarct. We will organize this using a simple schematic. The real heart is beautiful but complicated, so we'll simplify it. Here, we'll represent the left ventricle as a simple square character. Mr. LV. We'll use two schematic views, a top view and a frontal view. So this is top view and this one is frontal view. Let's map the 12-lead ECG on the schematic. Precordial lead from the anterior perspective, anterior wall 3, 1, 2, 3, 4. These are anterior wall. And V5 and 6, those are lateral wall. 7, 8, 9 are posterior wall. With this, you can immediately identify which leads correspond to which myocardial area. And next, let's move on rim leads. On the frontal view, 2, 3, AVF, those are inferior wall. And left lateral wall, lead 1 and AVL. The opposite side is cos AVL. These same is this lateral wall. Okay, next let's check corresponding coronary arteries. Anterior wall is LAD and lateral wall is LCX. Inferior wall usually RCA, but 20% are LCX dominant. And the last one, posterior wall, is same RCA or LCX. So now, this is the basics of STEMI ECG, but I want to tell you two more clinical important things. Number one, reciprocal changes appear on the opposite side. If the posterior wall shows ST elevation, the anterior leads appear as ST depression. So if you see ST depression in the arterial leads, consider posterior MI and check V7 to 9. And the famous pattern is plus tau R in V1 to V2, often seen in posterior MI. This is a key to find posterior MI from ECG. And the second one is don't miss right ventricular MI. If you suspect RVI, you must record right side chest read V3R and V4R. These reads often reveal ST elevation that is invisible in the standard 12 reads. In other words, if you don't actively record right side read, you will miss right ventricular infarction. So when should we suspect RVI? Let's briefly touch on some clinical situations. First, when V1 show isolated ST elevation, the right ventricle rises anteriorly, so isolated V1 elevation suggests RVI. And when STEMI involves the inferior reads, 2, 3, AF. 30 to 50% of inferior STEMI involves the right ventricle. Be especially cautious when lead 3 shows more ST elevation than lead 2. And third, when the patient has hypotension, it's jugular venous distension, but minimal pulmonary congestion. This pattern indicates impaired right ventricular filling and reduced preload to the left ventricle, a classic sign of RVI. And last, blood pressure drops suddenly after giving nitrates. RVI patients are preload dependent. Nitroglycerin can cause abrupt hypotension. In any of these situations, record V3R and V4R uncover the hidden ST elevation and confirm the diagnosis. This simple schematic approach allows you to understand STEMI patterns clearly and systematically. If you remember the relationship between myocardial regions, ECG leads, and coronary arteries, you will have a highly practical framework that works both in exams and in real clinical practice. See you on the next video.